Methamphetamine, bath salts, and other amphetamine-related derivatives. Progressive Treatment Update. Authored by John Richards, M.D., Robert Derlett, M.D., Tim Albertson, M.D., Ph.D., M.Ph., all from the University of California, Davis Medical Center, Zane Horowitz, M.D., Oregon Health Sciences University, and Richard Lang, M.D., M.B.A. from University of Texas Health Science Center. Abuse of amphetamine, its analogs, and related derivatives, abbreviated in the paper as AAD, is a growing worldwide problem. AAD include methamphetamine, MDMA, cathinone, bath salts containing mephedrone, and over-the-counter decongestants such as pseudoephedrine. Patients presenting to the emergency department with toxicity from AAD are often agitated, psychotic, and have markedly elevated heart and respiratory rate, blood pressure, and in some cases hyperthermia. The long half-lives of these drugs places patients at risk for serious secondary injuries such as acute coronary syndrome, stroke, arterial dissection, rhabdomyolysis, and acute renal failure. To prevent harm to the patient and emergency department staff, rapid agitation control is essential. Sedatives which can be given IV or IM are preferred in this setting. Benzodiazepines such as lorazepam, diazepam, and midazolam are good first-line agents. However, multiple dosing is often required, which increases the risk of respiratory depression. Antipsychotics such as haloperidol, droperidol, and the newer agents olanzapine and ziprasidone are also effective. However, these agents may increase the QT interval and risk of extrapyramidal side effects. Dexmedetomidine is also effective for control of agitation, but is not widely available in most emergency departments. Ketamine is also effective but tends to raise heart rate and blood pressure, which may be problematic for these patients. Propofol and ketamine plus propofol, otherwise known as ketofol, are also potential agents for control of agitation, but require a drip and constant bedside presence for the busy emergency physician. Lipophilic beta blockers which cross the blood-brain barrier, such as metoprolol and labetalol, may also be useful in mitigating agitation. If the above interventions fail to control agitation, rapid sequence induction and intubation is the final step. Once agitation has been controlled, persistent tachycardia and hypertension must be addressed. Beta blockers are the most commonly used agents for this indication. Many human and animal studies, case series, and case reports have shown beta blockers to be safe and effective in the setting of AAD toxicity for control of both tachycardia and hypertension. Selective beta blockers with additional alpha-blocking properties are preferred, such as labetalol and carvedilol. The use of labetalol for AAD and cocaine toxicity is approved by the American College of Cardiology Foundation and American Heart Association. There were no unopposed alpha stimulation events in our extensive literature review of beta blocker treatment. Alpha blockers such as phentolamine have been used to control hypertension but not tachycardia. Nitric oxide-mediated vasodilators such as nitroprusside and nitroglycerin may be used with the understanding these control hypertension but not tachycardia. Calcium channel blockers have been shown to control hypertension but not tachycardia in multiple studies involving AAD and cocaine. Conclusions. For AAD toxicity, rapid control of agitation is essential. Benzodiazepines and antipsychotics are first-line agents. Dexmedetomidine is also a promising agent for this indication. After agitation has been controlled, persistent tachycardia and hypertension should be treated with selective beta blockers, preferably labetalol. Calcium channel blockers, nitric oxide-mediated vasodilators, alpha blockers control hypertension, but not tachycardia. The dogma of unopposed alpha stimulation for beta blockers in the setting of stimulant toxicity has appeared in medical literature for decades despite scant evidence. This should be questioned by present-day clinicians using evidence-based medicine.